So should we get started then? A couple of people still coming in, but I think we can probably get going so that we can use the most amount of time we have possible. So to start, I am Marina Adshade. I am a member of the Women's Health Cluster, and it's proud to be. I'm an economist, so I'm a little bit different from the other members. It's been such a wonderful experience for me to meet all these amazing women and who bring together so many variety of perspectives and learning. So I'm really delighted to be able to be here today to host this event. I'm very, very excited to have Angela here today. I actually will totally ruin your name because I forgot to ask you beforehand how to pronounce it. Is it Kaida?
Kaida.
Kaida. Okay. Sorry.
No problem.
So Dr. Angela Kaida is Associate Professor at the Faculty of Health Sciences at Fraser University. She holds the Canada Research Chair in Global Perspectives on HIV and Sexual and Reproductive Health. She is a local and global research she leads a local and global research program focused on factors and environments that increase vulnerability or protect sexual and reproductive health in the context of HIV. She works closely with community leaders and decision makers to integrate research evidence into health policy and programming, attending to social and gender equity. She has served on numerous institutional, national, and global leadership roles, including with the WHO Department of Reproductive Health and Research, the Sub-Saharan African Network of TB and HIV Research Excellence, Canadian Association of HIV Research, and the BC Women's Health Research Institute. I have a fun fact here to share, which we had a little bit of a conversation beforehand, because the fun fact is that unlike other avid hobbyists among us, Angela has accomplished very little in the way of personal growth during the COVID crisis, but I assured her that she is not alone in not engaging in any hobbying during the last, what is now like 13 months. I assure you, unless drinking red wine is a hobby, I have accomplished very little myself. Before we hear from her, I want to make sure that we acknowledge the land that we're on. We recognize that we live, work, and play and participate in community on the unceded, ceded, and charter territories. My Zoom screen is sitting on top of this. Oh, okay. I have to hold you over. And traditional territories of 203 First Nation, along with 38 Métis chartered communities, each of which possesses their own unique traditions and history here on this land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous People, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous culture and traditions. I am joining you today from the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. As Lisa knows, because we've had conversations about this before, this land acknowledgement is actually very important to me. We hear a lot of land acknowledgements today, which always makes me happy. But I just want to make sure that everybody recognizes that this is not rote process for us, that we feel quite deeply committed to these ideas. Okay, so for any of you who are new to us, the Women's Health Research Cluster has more than 250 members that are scientists, students, and community members that live and work in 11 countries around the world. We have a number of different events for diverse audiences, give out several awards to student members, and collaborate with community partners. If you're interested in becoming a member, go to our website and click Become a Member. Membership is free, and it gives you access to members-only services such awards and research facilitation. And also it's a great way to keep abreast of things that we're doing and events that are coming up in the future. So with that, I am going to hand this over to Angela, and we look forward to hearing your presentation.
Thank you so much, Marina. Thank you for that introduction. And hello to everybody on the line today. So as Marina said, my name is Angela Kaida. I'm an associate prof in CRC in the Faculty of Health Sciences at Fraser University. And the title of my talk today is Love, Life, and Family, Safer Conception Care for HIV Sero-Different Couples Who Desire Children in Uganda. And so I am also here on Coast Salish territories, where I'm honored to live, work, learn, and play, specifically the shared traditional territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations. So I'd like to actually begin my talk today with a memorial, a really loving memory for Dr. excuse me, for Dr. Bosco, Dr. Mwebesa Buano Bosco, who passed away in October of last year. And I was actually due to deliver this talk in early November. And thank you to the organizers for accommodating me. It was a sudden and very difficult loss for me personally and for our team and for his family. So Dr. Bosco was a senior doctor, researcher, and HIV specialist at the ISS clinic at Mbarara Regional Referral Hospital in Uganda. He was a co-principal investigator of the work that I'm presenting today. He's also a colleague and a dear friend. So I present this work today in his loving memory. So today, what I would like to go through with you is I'd like to start with some overview of what it means to minimize periconception HIV transmission risk, and then share with you some of our formative research on pregnancy intentions and pregnancy in the context of HIV, primarily from Uganda. And then to introduce and share some of our work on what's called the Healthy Families Clinic, which is a clinic that we initiated in Mbarara focused on safer conception. And then some preliminary results from a new study that we have that's focused on men living with HIV. And I wanted to share that here. I know this is the Women's Health Research Cluster, but I wanted to kind of link in some of our findings there as part of this discussion. And then some last two thoughts of, I've got love in the title, but like, what's love got to do with all of this? And then some final learnings that I'll share. So that's our journey today. But I'm going to start us off on this journey by telling you a bit about Mary, who's a young woman, 24-year-old woman living with HIV. I first met her in 2010. And at 24 years of age, she's part of a generation of young women who have never known a world without HIV. And in her young life, she had experienced a lot of loss, HIV-related loss. She lost her own mother, her sister, to HIV-related causes. And even though she had this experience and the prevalence of HIV and pregnancy in her own community is really high, she felt like talking about pregnancy as a positive woman was taboo. She was really worried, like, would anybody want to have a baby with her if she disclosed her HIV status? But still, like, despite all of these worries and risks, having a baby was imperative. So she says here, I am more than HIV. I want to be a mother, and HIV cannot take this away from me. And so even though Mary felt really desperately alone in her desires of motherhood as a positive woman, her experience is really far from uncommon. And so I'll just take us back out to this global picture. COVID has helped us think about numbers differently as a global pandemic. And so I'll just share with you that today about 37.9 million people around the world are living with HIV. And this map is color coded. So as countries or regions are colored a darker red, the adult prevalence of HIV in that country is higher. So the darkest red countries in Eastern Africa and Southern Africa, you can see where HIV prevalence in the adult population ranges from 5% to up to 28%. And in fact, 68% of all people living with HIV around the world today are living in the African region. And I also need to say something here about HIV and women, because globally, women comprise more than half of all people living with HIV. And the primary transmission pathway for women is sex with men. And when we look at incident infections, we're seeing this sustained pattern. Close to half of all new infections globally are among young women. And in the sub-Saharan African region, women and girls account for 59% of all new infections. So this gender gap is actually exacerbated when we look at younger women, many of whom are initiating their sexual lives, many of whom are initiating their reproductive lives. But really we see this gap extending, where we have 5,500 young women aged 15 to 24 become infected with HIV every week. And the risk for young women is about threefold higher than it is among age-matched young men. So when I think about Mary as a young African woman, is she alone in her experience of HIV? Absolutely not. But is she alone in her desires for pregnancy and motherhood? Nope, she's not. So we know that women and men living with HIV around the world desire children and have children. These stars just indicating some of the sites where this research has been done. So we're seeing it occur around the world. And our estimates tell us that about 30 to 50% of women and men living with HIV desire children after learning about their HIV status. And then about 10 to 50% of them are actually having children. And when we consider these rates of pregnancy, desires, as well as the actual incidence of pregnancy, of course, one of the considerations is about HIV transmission risk. And for many years, really that focus was on perinatal HIV transmission risks, so risk to the babe, as well as the health and survival of the mom herself, both of which are critically important, obviously. But in addition to these risks, we also have risks of transmission during conception attempts, since the vast majority of these pregnancies are going to happen through condomless sex. And a meta-analysis showed us that about half of all couples affected by HIV in sub-Saharan Africa have one HIV positive member of that couple and a primary partner who is not living with HIV. So these are what we call HIV sero-different couples. And while we don't, and these sero-different couples are really important for our HIV prevention initiatives, because modeling studies show us that about 60% of all incident HIV infections are attributed to transmission within these stable HIV sero-different couples. And yet what we don't know yet is what proportion of these transmission events are occurring in the context of desired pregnancy. But we do know that they play a very important role in ongoing transmission and ongoing spread of HIV. So if we take it back to fertility intentions and fertility goals, even though those are reproductive rights, we know that without support, a lot of HIV affected women and couples will kind of accept an increased risk of HIV in order to satisfy their own reproductive goals or their partner's reproductive goals. But many of them are facing these risks unnecessarily, because we have safer conception care, which provides a treatment and prevention approach that supports the realization of reproductive goals while minimizing HIV transmission risks for the mom, for the partner, and for the babe. So let me just back up a moment, because I'm not sure if I'm speaking to an audience that knows a lot about HIV or not. So I'll just say quickly that we now know that with access to HIV care and standard treatment or antiretroviral therapy, people living with HIV have a completely transformed reproductive landscape. Increased life expectancy, nearing that of HIV negative individuals, decreased morbidity, dramatically decreased risk of perinatal transmission, and decreased risk of sexual transmission. And this final benefit, which we know as treatment as prevention, was first actually discussed quite a few years ago from observational data and then data from randomized controlled trials that showed us that the risk of sexual HIV transmission was directly linked to the viral load of the person living with HIV. So people with HIV who were on antiretroviral treatment and had an undetectable viral load had what we said is effectively no risk of transmitting HIV to a sexual partner. That's the language that we started with. But since those trials, we've had additional observational studies where which assessed risk of HIV transmission among people who were on treatment and with an undetectable viral load. And these studies consistently found that there was no linked transmission events among heterosexual and same-sex sero-different couples who reported condomless sex. So this is the science that underpins a global initiative that's known as U equals U, or undetectable equals untransmittable, saying that a person living with HIV who has an undetectable viral load cannot transmit HIV to their sexual partners. So this is quite transformative on what can be done in the realm of sexual and reproductive health with HIV. But we also have another tool in our HIV prevention toolkit that can be used to support reproductive goals, and that is HIV pre-exposure prophylaxis. So this is when the person who's not living with HIV takes antiretroviral drugs, a formulation of antiretroviral drugs to protect themselves against acquiring HIV infection. And we now have dozens of trials that show us that PrEP works when you take it. So as long as the person is adhering regularly to PrEP, it provides a very effective tool to prevent HIV infection. Now, how does this all come back to relating to safer conception? So those are two of the ARV-driven HIV prevention strategies that can be used to minimize peri-conception HIV transmission. So these biomedical strategies can be used in combination with behavioral strategies that can support pregnancy attainment with minimal HIV risk. So if in an HIV affected couple, if the person living with HIV is the woman, then manual insemination and or medical male circumcision can eliminate, in the first case, or reduce by about 60% the risk of HIV transmission during conception attempts. If the person living with HIV is the man in the partnership, then sperm washing with assisted reproductive services can be used to eliminate HIV transmission risk. But unfortunately, this type of technology is not really available or accessible to the vast majority of HIV-affected couples who could benefit from it. But in both of these situations, or both of these combinations, antiretroviral therapy with viral suppression for the positive partner, use of pre-exposure prophylaxis for the negative partner, alongside timing sex to peak fertility and testing and treatment for STIs can be used to eliminate HIV transmission risk during peri-conception attempts. And so this science has been cultivated and put together in a lot of different formats, and a few countries, including here in Canada, actually have guidelines to support pregnancy planning or safer conception for HIV-affected couples. And in 2018, our team put together we published a consensus statement where a global consensus statement where we summarize the evidence regarding the efficacy, effectiveness, safety, acceptability data that supports the use and uptake of a wide range of safer conception strategies. And in this consensus statement, we also highlighted some of the factors that are limiting implementation and opportunities for action, and some guidance around like what we need to do as a global community to get over those limitations, right? To stop kind of getting in our own way. And our own team's decade of formative research on HIV and reproductive health in Uganda has contributed to these guidelines and some of the other country-specific guidelines. And so I'd like to share some of those research findings with you today. So before I do that, I need to introduce you to Uganda just very quickly. So it's a landlocked country here in red in I guess, Central East Africa. It's bordered to the east by Kenya, to the north by South Sudan, to the west by the Democratic Republic of the Congo, and to the southwest by Rwanda, and then actually to the south by Tanzania. So there's about 43 million people living in Uganda, and the country is about, I was trying to think about like what was comparative, but it's about the size of Oregon State. So just some sort of geographic reference. It's also known as the Pearl of Africa. I think this is a term attributed to Winston Churchill, who visited in the early 1900s and was very enthused by its beauty and the bounty of the country. And I have been privileged to work in the southwestern part of the country in Mbarara district. It's about 265 kilometers southwest of the capital city of Kampala. And Mbarara is home to the Mbarara University of Science and Technology, or known as MUST, which houses one of the country's 2 medical schools. And our research is based at the ISS clinic, the Immune Suppression Syndrome Clinic, which is the main referral HIV treatment and care clinic at Mbarara Regional Referral Hospital, which you can see in this very beautiful photo taken by one of our clinical fellows. And our formative research was led by an interdisciplinary team in collaboration with staff and collaborators and investigators from MUST, from Mass General Hospital in Boston, Harvard Medical School, as well as SFU. Now, in addition to having a great looking campus and a great looking team, as you saw, there are really several features about Uganda that made it the right location to do this kind of research. Firstly, HIV is firmly established in the general population. So the HIV prevalence is 5.8%. And you can see it's quite a bit higher among women, 8.8% compared to men at 4.3%. The antenatal care prevalence of HIV in Mbarara itself is 12%. And Uganda has quite a high total fertility rate, I think among the highest in the world, with an average of 5 children per woman. So we started our research there looking at, well, as antiretroviral therapy became more widely available in Uganda in the late 2000s, I don't know how we say that, about 2006 onward, we wanted to see, okay, where are we going to start to see this shift in pregnancy, in the number of pregnancies that were occurring among women living with HIV as access to antiretroviral therapy increased. And with funding from the NIH, we examined pregnancy incidence among 351 women living with HIV who were initiating treatment. Okay, this was between 2005 and 2011, and then we followed them quarterly. And what we found was actually a pretty high pregnancy incidence among women of 9.4 per 100 woman years. And really what you can see from this Kaplan-Meier curve is that by about 3 years after initiating ART, cumulative probability of at least one pregnancy was 28%. And when we looked at this number for younger women, so these are women under the age of 35, that cumulative incidence of pregnancy rose to 42%. So we're saying, okay, once women start treatment, once women living with HIV start treatment, like nearing half of them are going to be pregnant within 3 years of starting that treatment. And we also had a chance to look at this question among men. And the language is a little bit awkward because these are men living with HIV who are reporting to us pregnancies among their partners. Okay, so partner pregnancies. And here, again, looking at men who were initiating ART, and we found an even higher incidence of partner pregnancy here of 16 per 100 person years. And among the men living with HIV, 30% of them reported a partner pregnancy. And what was really kind of quite interesting to us is that there was no difference in the incidence of pregnancy, whether men had an HIV seroconcordant partner, so the woman is also living with HIV, or a negative partner, because she's not living with HIV. The incidence was like almost identical. The other thing that we could learn from this study was that most of these pregnancies, like 92%, were reported, at least by the male partner, as being intended and being wanted. So, we weren't able to look at that information among the women who were in our study, but among men, it was really suggesting to us that yes, we've got a high incidence of partner pregnancy, and those are intended pregnancies, right? Suggesting this is a really important group potentially to focus on for safer conception work. And the other part that our other findings that supported that conclusion was that about half of the pregnancies were with HIV negative partners or partners where the man didn't know his partner's HIV status. And in addition, about a quarter, even though these were all men who were initiated on treatment, about a quarter of them were not virally suppressed during the periconception period. So that is indicative of, there's condomless sex happening in order for this pregnancy to occur. And we have about a quarter of the men who are not virally suppressed, presenting risk to their HIV serodiscordant female partners. But, as we started to think through, okay, well, look, there's things that can be done about this, right? This is an unnecessary risk that's being taken to pursue these reproductive goals. But as usual, it's not always as straightforward as you hope. So there were a few complicating factors, and there's really quite a rich body of literature from mostly qualitative research that highlights how important like social and relationship challenges are and how they shape the pursuit of pregnancy in the context of HIV that are very essential to consider in the context of safer conception. So the first one is even this concept of serodiscordance, like this assumption that, oh yes, we know, everybody knows their status. They've told the other partner, you know my status, I know your status, we're good, we can talk about it, we can carry on. But that is really uncommon, actually. There's a whole bunch of other combinations of what these partnerships can look like. And actually, research shows us that a minority of men and women living with HIV who were planning a pregnancy knew their partner's HIV status. That's not the starting point. It's actually a minority. And disclosing HIV status in the context of pregnancy is very fraught with challenges. Many of these challenges can be very gendered. So it's not uncommon for disclosure to happen after a pregnancy is confirmed to avoid risking a relationship being dissolved. So in this case, one of the men living with HIV who was participating in one of our qualitative studies shared with us that he didn't want to tell his partner about his HIV status in case she decided like she didn't want to pursue parenthood with him. So he says, yeah, like now for her, when she came here, being that she moved in with him, I came to the hospital to get the drugs and I called her and I told her, oh, things are hard. I'm sick. I'm really sick. But I was lying. I knew it. I knew my HIV positive from long ago, but didn't want to tell her before the pregnancy was confirmed. So, our first learning here is that really limiting our conversations about supporting reproductive health and safer conception to mutually disclosed HIV-affected couples is really going to exclude a lot of people who need these services and this care. We had another challenge, which is the fallacy of restricting services to women with HIV who are trying to conceive. This language drives me nuts, but this is the language that is commonly used. And this is a study by a colleague, Cherie Schwartz, looking at women in Johannesburg, actually, and measuring incidence of pregnancy by time-varying fertility intentions over time. And what we see here is that, yes, women who report that they are trying for pregnancy do have a higher pregnancy incidence over time. But by 3 years after ART initiation, nearly 40% of women who said that they were not trying for a pregnancy or not trying to conceive did become pregnant as well. So it's kind of artificial to distinguish, to think that you're going to target only those that are trying to conceive. And then we also wanted to look at provider perspectives. So are we in an environment where providers could provide some support to HIV-affected couples looking to conceive or thinking about their fertility goals? And what we found was quite limited assessment of fertility plans in general. So very seldom asking women living with HIV if they wanted to have children, and virtually never asking men. And we also saw a lot of remaining stigma about people living with HIV pursuing parenthood. So this nurse says, like we always tell them, if you have this child and you seroconvert, it's not our problem. It's your choice to have a child. It means that you're not practicing any safer sex methods. You're just having live sex, which will bring in other risks. And by live sex, she means condomless sex. And then there are other providers who are a bit more empathic, but they really struggle to know what to do. Like she's saying that counseling for serodiscordant couples wishing to conceive is like also really hard, but we try. And I think if we could all get training in reproductive health, we could do it better. And this kind of makes sense, honestly, because after decades of promoting and pushing condom use as really the only way to protect people from acquiring HIV, providers really struggle with this shift of messaging of like, oh, you cannot use condoms and you can be on treatment and you can be virally undetectable, or you can use PrEP. You can use these other methods and not risk transmission and still provide opportunity for conception. So it kind of led to this situation called like what we call referral as deferral. So, you know, a woman or a man goes to a counselor. Oh, can you tell me about how I could become pregnant? And the counselor doesn't know. He refers to the nurse, who doesn't know, who refers to the doctor, who refers to some specialist in some city that this poor couple is never going to have access to. So there was just really no space to be providing these kinds of services, even though we knew what would work. But based on this formative research and the growing evidence around safer conception, Dr. Bosco, a very fierce advocate for patient-centered HIV care, decided that safer conception care didn't need to be in the realm of specialists. It could be situated within the ISS clinic in Barara. And he started a clinic to do exactly that. So he led the implementation of what is called the Healthy Families Clinical Program, which is a safer conception program within the HIV clinic in Barara, targeting people living with or exposed to HIV who want to have children in the next 2 years. And as part of this program, the nurse and the counselor provide comprehensive safer conception counseling. We've developed a booklet and these tools using locally developed evidence and research and language. It goes beyond the actual technical strategies to talk about disclosure, communication skills, pregnancy readiness, and introduces and really emphasizes and shares this evidence of U equals U with participants as a form of reducing stigma. And so just wanted to share with you like who actually came, you know, like build it and they will come, but who does come? And we were really amazed. We didn't really have a target of like, oh, we want to provide services to this many clients. We weren't really doing active recruitment. We were just letting people know that there was this service available. And so we've had 361 index clients that have accessed the services of this clinic. You can see their median age here, ranging from quite young, you have to be 18 to receive the services, but up to ripe old age, still looking to conceive, to have children. But the other thing that was very interesting was the gender divide. About 53% of clients coming forward were men, and nearly all of them were men living with HIV, compared to women, where we had about equal numbers who were living with and not living with HIV. And most safer conception work really focuses on women living with HIV already. So we were very interested to learn how much demand there was out there for other HIV affected groups. And we saw that the median time trying for pregnancy, so probably doing other, you know, having condomless sex, trying to become pregnant without the support of safer conception care, the median time was 6 months, but it ranged from people who were just sort of starting to think about it to people who'd been trying for, 10 years. And of course, introducing HIV risk, transmission risk throughout that time unnecessarily. And so these data from the Healthy Families Clinic program really alerted us to the demand for safer conception care among men living with HIV. And we really don't know very much about heterosexual men and reproductive health and HIV, even though we know, as I showed you earlier, that fertility desires are high, partner pregnancy incidence is high, but we don't really do a great job of engaging men, heterosexual men, in HIV care. And they're really largely absent from sexual and reproductive health programming in many of the areas that I work in. And this is a big problem because, for lots of reasons, including the fact that men often play a very dominant role in decision making when it comes to reproductive goals, HIV prevention practices, planning for, families and that sort of thing. They play such an important role, but are, have not been very well engaged or served in sexual and reproductive health programming. So we launched the Getting to Zero study to start as a pilot study to start looking at some of these questions. And the importance of working with men was further emphasized because of the extensive gender inequities or gender disparities in engagement in the HIV treatment cascade for men. So as you now know, that being on ART with an undetectable viral load presents benefits to individual health. Like if I'm undetectable, I'll live longer, less sickness, as well as prevention benefits, HIV prevention benefits. But men in Uganda are less engaged across the HIV care cascade than women. So UNAIDS estimates tells us that, we have these goals of 90, 90, 90. And you can see how far men are from achieving those goals. We only have 67% of those who are living with HIV know that they're living with HIV. Only 62% of those are linked to HIV care, and only 47% of those are virally suppressed or virally undetectable. And this really differs because among women, these numbers are all closer to about 80% in Uganda. And it's, for those of you who do work in HIV here in Canada, you'll know like this is exactly flipped. In Canada, it's women who are under engaged in the treatment cascade, but in Uganda and most of sub-Saharan Africa, it's men. Now, this has major consequences for the men, but it also has major consequences for women, because when men are not linked to care and virally undetectable, they continue to transmit HIV to women. So these are data coming out of a large population-based study in South Africa, where you can see on this side, this is HIV incidence in men. And over time, we see this pretty dramatic plummeting that correlates with an increasing ART coverage among women in the same community. Whereas among women, we see a pretty stable, maybe slight increase in HIV incidence around the same time, largely because we have such a slow increase in men's engagement in ART coverage. So women's health in this case is very much linked to whether men are engaged in HIV care. So we wondered, could safer conception care provide an innovative way to engage and retain men living with HIV in HIV care? So we wanted to, in our pilot study, we wanted to look at these questions. We had one quantitative characteristic to see who shows up, which men do show up for safer conception care, and what are some of the outcomes. We also had a qualitative objective to figure out what were their motivations, what were the challenges, what are the benefits for this care for men. So I'll just tell you quickly that in this quantitative part of the pilot study, we enrolled men who desired a child in the next year and who had a sero-different female partner. And we enrolled them at baseline and followed them up at 3 and 6 months, and have actually got extended funding to look at their 18-month follow-up. But I can't present those results today because we just closed that data collection and I have to present those to our Ugandan team first. But I'll hopefully be able to come back and let you know what's going on there. But we were also, as part of doing this, the men were offered safer conception counseling at the Healthy Families program. We did lab testing for STIs, HIV RNA, and pregnancy testing with this follow-up. So just really a snapshot to show you that the men who came forward had a lot of diversity in who came forward. Education levels, some were had below primary education, but many had above secondary education. They were mostly employed. Most of them, by far, I think all of them actually already had children. So these were men who had experienced fatherhood and were seeking support to do so without risking HIV now in this context. You can see that condom use was fairly low, not too much of a surprise given that these are all people who want to have kids. And also you can see that most were on treatment and virally suppressed. So they were already getting some benefit of reducing the HIV transmission risk. But before they came, so they enrolled at baseline. 3 months later, we'd ask them, did you know about safer conception before you came forward? About 31% of them said that, yeah, they were, but most were not. But after that first visit, 81% of them actively chose to use and implement a method. Of course, not surprisingly, the most commonly used method was ART with viral suppression because most of them were already on treatment. But many of them also opted with their partner to double up or also use PrEP, timed sex, and then some who were reporting, we're going to use condoms until I have confirmation that I'm virally suppressed. And what were some of our preliminary outcomes? Well, in the first place, we had high retention. So 95% of the men that we enrolled at baseline came back for 3 months visits and came back for 6-month visits. So for retention, we were pretty pleased with that. The other interesting outcome was that we saw an increase in the proportion of men who came back to the safer conception care with their partners. So from 0% at baseline to 45% to 57% at 6 months. And then the big ones, the big outcomes of the partners, female partners that did come back at our 6-month visit and who were offered testing for pregnancy and HIV, we saw that 30% of them were already pregnant by 6 months. So they'd come for this goal. They wanted to conceive as a partnership, and 30% were already pregnant. And thankfully, wonderfully, 0 of the female partners had seroconverted. And I can just let you know from our data at the 18-month follow-up, I'm really happy to say that still we have no HIV seroconversions in this study. So quickly, we also conducted 40 semi-structured interviews with a subset of the men living with HIV and their female partners. And these interviews really revealed for us 3 main themes. I'll just talk you through these 3 main themes quickly here. The first one is about motivations. And there's really not too much that's surprising here. Like men in Mbarara, like men living with HIV probably anywhere, are motivated to participate in this kind of care because they want to have children. They want to have an HIV negative baby. They want to protect their partners from acquiring HIV. And I think importantly, they really reported that they wanted to learn how do they improve their lives and their relationship living with HIV. And when it comes to challenges, some were not too surprising to us. So some of the challenges I mentioned earlier about disclosure, right? Fears about disclosure, delays in disclosing, being worried about reactions, navigating power inequities as you make decisions and as a couple about pregnancies was very challenging. But there were 2 here that really kind of were new to us. The first one being couples reporting some lingering uncertainty about the effectiveness of ARTs as prevention. And this kind of comes together because we've got groups of, we're kind of promoting multiple methods. So they're sort of saying to us like, well, if that method works so great, why are you giving me PrEP and all of these other things? Right. So this is a woman who says, when we came here, they told me about PrEP drugs and how it prevents you from getting infected. So if they thought that ART drugs would work alone, then I think they wouldn't have given us these drugs. And then a final challenge really about being frustrated with the delays in achieving conception. Our team, we're thinking about HIV and we're thinking about HIV prevention, but so many of these couples are coming to this clinic to get support to become pregnant. So he's saying here, I joined this program because I wanted us to have a child, but she's not yet gotten pregnant. So what else can I say? Because if you want something and you haven't gotten it yet, can you feel happy? I mean, it's just so like straightforward. And then benefits. So the men were expressed benefits of getting knowledge and support for realizing reproductive goals. They also talked about benefits around accessing other types of sexual and reproductive health services like STIs, benefits about alleviating worries about risks of HIV transmission. And then this benefit where they spoke about improvements to their relationship and to sexual intimacy. And this is where it comes in of like, what's love got to do with this? And it was really remarkable to see throughout our data and throughout our analyses of how much the participants, the men and their partners, talked about how this type of care that acknowledges reproductive goals and desires contributes to the intimacy of their relationships. So I'll just share one of these quotes here today, but I've kind of highlighted where they love each other and they have gone back to the love that they had for each other. This is really everywhere in our data that we weren't anticipating. But this woman at the bottom here, she says, it has helped us in many ways. It has taught us how to love. We know that even if he is sick, we can live. I found love and learned to love myself, even if my partner is HIV positive. So again, like I said, we were really quite surprised to see how much our participants talked about this very intimate impact in their lives and in their relationships, and really talking more about pleasure, sexual pleasure, and quality of the relationship. So what were some of our learnings then across this work that I want to leave you with today? The first one, that men are really eager to participate in novel care that incorporates family building goals. I think we've really seen that there's a need and a demand for such services, and that the motivations to do this extend beyond just wanting children. It really is so much more than that, about learning to improve life and love and family with HIV. There's still this uncertainty about the effectiveness of ARV-driven HIV prevention methods, which is just sort of making me think a lot about how so much of our messaging is so medicalized and so much is so pathologized, that if we're going to really have impact in this space, we've got to think about the messaging beyond just the medical effects or the clinical effects of treatment as prevention. And I think importantly, when we're working in spaces where your focus is, I'm really focused on HIV, so sometimes that puts blinders, right, where we're to see the bigger picture here, because so many of our participants perceived delays in conception as failures of safer conception care. So there is something more here about how maybe people are seeking this care for infertility support rather than HIV prevention, and how are we going to incorporate all of that into providing patient-centered care? And then I think finally that the benefits that we're learning are including opportunities to improve relationship equity and enhance sexual intimacy, and maybe attending to these socio-structural contextual factors are going to present some better opportunities to better engage men in safer conception and HIV care, to improve both men's health as well as women's health. And so our participants were very insistent that we share this information. They were like, oh, you've got to take this out to the community. You've got to make sure that, other people who don't have the opportunity to come to ISS clinic to be cared for by Dr. Bosco can also know this information. So we hosted this a community workshop where we actually paid for data for community-based organizations all around Barara district to come and participate in a Zoom call. And we had 50 attendees representing community-based organizations who serve key populations affected by HIV in Barara, as well as members of our research team. And we shared some of this data with them and heard from them some of their priorities of like, we need data that looks like this, or we need to enroll more with people like this. And it was just like, honestly, such a gift in this global pandemic to still be able to connect with a global community, even if it was virtually, and talk about ways that we could extend this research and make sure that the findings are reaching those who need it most. And so on that note, I'll just close by making sure that I acknowledge the many members of our team, as well as the providers at the Healthy Families program in Barara, who we've worked together for many years now to make some of these findings possible. And again, to thank the organizers for inviting me here to share with you some of our learnings and some of our work to date. So thank you very much, and I'll end there and be open to any questions that you might have.
Oh, that was such a great presentation. So interesting. I think my only thing was I thought there could be more baby pictures.
Yeah, always.
I was hoping you were going to end with like a whole bunch of baby pictures. I was looking forward to that moment. We did get one. No, it's so interesting, and thank you for this, and also thank you for the amazing work you do. It's like such an important element of people's lives. So we don't have a lot of time left, but I think that we can take some questions if that's okay with you. I'm not sure that I guess I probably can't see if people put up their hands or if they want to write their questions in the chat.
Can I just ask one?
Yes. We'll let you ask one.
I think people can unmute themselves. I meant to write in the chat, but I was busy tweeting. Angela's talk, not tweeting other things, Angela. So one of the things that you mentioned that I thought, first of all, thank you very much. Really amazing work and really interesting perspectives on the need for, and respect for the people that are coming to the clinic themselves. Like why are they coming and what are their needs while they're there? So one of the things that you showed, and obviously not my area, that's why I'm looking, because I did take one picture, but was, I think it was a whole bunch of things like diagnosis, adherence to taking the antiviral therapy, and there's something else. And you said that they were at different levels linked to care, virally suppressed, diagnosed, and it was HIV treatment cascade for men in Uganda. And you said, and the goal is 90-90-90, but they're around like 62 to 47 or something is what your graph said. And you said, for those of you in Canada, it's flipped. It's the women that are, so that really intrigued me. So there's this sex by region difference. So any ideas about why that is?
Lots of ideas. But, I think the nature of the epidemic in Eastern Africa, Southern Africa, one of the main ways that activity started around HIV was because we're always very concerned about babies, right? So we're really concerned about babies acquiring HIV. And so, and honestly, to be honest, for a long time, we were not concerned about the mom, but we were concerned about the babies. And you know me, so I'm always like, I only care about moms. But so what happened is that sort of initiative of doing like antenatal screening for HIV, that's how women were being screened for HIV, but there wasn't really the equivalent for men. Like where is it that you're going to generally get screened for HIV? And because the fertility rate in several settings is so high, the likelihood that women are getting screened pretty regularly for HIV is quite a bit higher. And then once you've got women who are screened, they know their HIV status, sort of moving them into HIV care, particularly if they're pregnant, right? It's providing these pathways into the healthcare system that just doesn't really exist in the same way for men. So that's one pretty practical explanation. There's a whole bunch of other explanations about how men just seek care in general. No offense to any men on the line, but I think you know what I mean, around, not really actively health seeking, particularly because we just haven't done a great job of sexual and reproductive health programming for men. So the pathways are like the obvious methods to get them linked in. Where do you go for HIV testing? Why should you go for HIV testing? Just don't exist in the same way. So I think for women here, so anyway, maybe I'll stop there, Lisa, because it's a longer answer.
No, that's all good. The Marina probably has a question, but the other thing that resonated with me a lot about what you said was sort of about the lack of consideration of heterosexual men living with HIV. I thought that was also really interesting. I mean, it makes complete sense when you say it out loud, but something else that I had not considered. And then you said something else that was really interesting to me, something about like men's health matters for women's health, which of course it does. Even beyond HIV and the pregnancy risk and transmitting HIV with getting pregnant, but for other things too. But it just was really just well put. So thank you.
Oh, thank you.
You are correct that I have a question. So I would, one of the things, so as an economist, I'm actually interested in how expectations shape people's behavior. Mm-hmm. And I think this is one instance where you could, by providing people with information, by shaping people's expectations, it probably changes people's behavior significantly. So if you're in a relationship with somebody who is HIV positive and you're HIV negative, and you want to have a baby together and you don't have this information, the person who's HIV negative might just simply resign themselves to the fact that eventually they will be HIV positive. And so that they would just move forward and not take any steps to protect themselves. But with this information, you would and you see it in your data that people will postpone pregnancy until they are until the 6 months or whatever is passed. And I think that that's so interesting, right? Because if you tell somebody, especially if you're married, you have to use condoms for the rest of your life, or you're going to get HIV, people just won't use them, right? It's like a war of attrition where people are just like, I can't possibly achieve this goal of a lifetime of perfect condom use. Mm-hmm. And so I think it's so interesting because wider communication about this treatment could go beyond people who want to have children to the whole community.
Exactly. And it should be, for sure. I think you're exactly right. Like our own research has shown, like, if you don't understand the possibility of serodiscordance, your willingness to take any action to protect yourself is sort of negated, right? There's all of this data that shows that, while we've been having sex without a condom for a long time, like, I'm probably infected too. I'm probably living with HIV too. So should I do anything differently? Should I whatever? There's no point. Mm-hmm. So we see a lot of that kind of misunderstanding about HIV transmission risks that's just shape whether people are going to think that going forward there is something that you can do to protect yourself, or if they do find out that they're sero-different, often people will be like, wow, like God protected us, like, well, there's this other kind of element, and it's confusing, right? Like the messaging about HIV has been so dogmatic in so many ways that to kind of open ourselves up to like, oh, wow, you can have condomless sex, you can have babies. Nobody needs to get infected like through this process is really challenging the dogma of HIV prevention.
It's incredibly interesting. I think that we are out of time though, and I don't see any other questions. So I think that's all that's left is to thank you for this. So it's such a super interesting topic. I'm definitely 100% going to follow you on Twitter, and I encourage other people to do the same. Reach out to you if you have any questions. Is there any other business that I should be attending to? Here are we.
Maybe I'll stop share so we can see.
No, I think we have one more seminar next week. And I think there's a trainee presentation series coming up, but I don't know when, sometime in May. But I'm sure there'll be lots of tweets and emails about it. So thank you
Thank
so
you.
much. Thank you so much, Angela.
Everybody.